Okay, we'll wait just another minute to get started. Have most of you gotten through the STD PowerPoint? There's a lot of them. And some of it should be a review because you did some of the testing and screening guidelines in 571. We're really looking more at treatment, diagnosing and treating it in this course. Still several people coming on, so let's wait a second so I can see the beginning. And they're really, a lot of people get really bogged down with the STDs, and there's really not that many drugs. I mean, for the major STDs, when we go through these case studies, you'll see there's not that many drugs, especially, I don't want you to, you don't need to be learning all the alternative treatments and everything. Somebody asked that in the forum, and I answered, learn the first line treatment, but do know what to do if they are allergic to that, like for syphilis. There's, the first line treatment is penicillin, and for some people, that's the only thing that you can give. Like if you're pregnant, that's the only choice. So, know those. But you don't need to know the doses. You just need to know the drugs. Okay? And with the herpes, there's a ton of different regimes. You don't need to know the regimes. Just know, what the drug is. And they all end in the same thing. They're all cyclovirs. So, they're just different pancyclovir and acyclovir and things like that. So just know, you'd be able to recognize those. Okay. I'm going to go ahead and get started. So we're going to do some case studies. The case studies that I presented in the PowerPoint that was in lessons that I hope you've gone through a little bit. And this will kind of go through the treatment of the major STDs. And a lot of people think, that they're never going to see STDs in private practice. Well, they don't discriminate based on socioeconomic status or anything else. So you do see them, and a lot of them don't have symptoms, so you have to screen for them in age-appropriate people. Okay, so case one is Robert Forbes, and he's a 33-year-old male who presents to his doctor reporting purulent urethral discharge and dysuria for 3 days. He lives in Dallas with a history of travel to Las Vegas 3 weeks ago. He has a new female sexual partner, Laura, for 2 months. They've had unprotected vaginal intercourse 4 times a week, the last time being 2 days ago, and no oral or rectal sex. Also had a one-time sexual encounter with a woman he met in Las Vegas 3 weeks ago. That's Monica. They had oral and vaginal sex, and no condoms were used. And he has no history of urethral discharge or STDs, no sore throat or rectal discomfort, and negative HIV test 1 year ago. And when you're doing a history on someone for a possible STD, you just need to be very business, professional and businesslike, and ask them, about, without judgment, ask them about the number of sexual partners, what type of sex they had, and whether they used protection, and just, do it in a non-judgmental way. They're a lot more likely to answer you if they've had. I mean, you're not there to judge them, and you're not there to tell their wife or anything else. So that's up to them. So, and when you do a physical exam, you have to also think, where could they have infection? Not just, there's oral sex, anal sex, and vaginal sex, so they can have infection in any of those orifices. Physical exam, vital signs were basically normal. There's no fever. He's cooperative and a good historian. Chest, heart, musculoskeletal, abdominal exam was normal. He didn't have any flank pain on percussion. He had a normal rectal exam and no sores or rashes. And the genital exam revealed a reddened urethral meatus with purulent discharge without any lesions or lymphadenopathy. And you always want to do a skin exam because some of the STDs give you a rash. What areas specifically of the skin should you look at that you wouldn't normally look at, where you don't usually see rashes? 2 places. Anybody think of them? The palms of hands and the soles of the feet, correct. Those are unusual places to get rashes, but those are where you get rashes if you have syphilis. So you always want to take their socks off and look there. So what should be included in the differential diagnosis? And let's just go one by one. What things should be included in differential diagnosis for this? He's got discharge and dysuria. Okay, chlamydia, gonorrhea, syphilis. So he could have any of the STDs. Could he, and with his history of multiple partners and unprotected sex, could he just have, Jocelyn says urethritis. He could have a prostatitis or some other thing that's causing urethritis. So what laboratory tests would be appropriate to perform on him? Cultures, NAT tests, the nucleic acid antibody tests. And then we'll talk about specific regime in a little bit more. So basically, and then Natalia is saying RPR and Brittany is saying HIV. You want to test. If he's had unprotected sex with multiple partners, he needs to be tested for all the STDs: chlamydia, gonorrhea, HIV, and syphilis. Okay, so differential diagnosis: urethritis, gonorrhea, chlamydia, and you want to do the NAT test for gonorrhea and chlamydia. It's the fastest, and it's the easiest to do. After working at the health department for so many years, we had to do the Gen probe, which was a urethral swab, which most men did not like. It was, not a fun experience. And now the NAT test for GC and chlamydia can be done on urine for either men or women, or it can be done on a urethral swab or a cervical swab. So it's much easier, and they're much more likely to accept having that done. And then HIV and RPR or VDRL to test for syphilis. Okay, so laboratory results, they're urethral, and if he's had unprotected or he's had oral sex, then you want to do a culture of the pharynx too. The urethral and pharyngeal swabs showed growth of gram-negative Diplococcus, and the biochemical and FA conjugate testing confirmed that it was Neisseria gonorrhea, so he has gonorrhea. The NAT test for chlamydia was negative. The RPR was non-reactive. His HIV antibody test was negative. So what is the diagnosis based on this? Gonorrhea. Okay. Let's go back. Okay, so what is the treatment going to be? What's first-line treatment for gonorrhea? Okay, Rocephin. Okay, Brittany's saying cephalosporin, but specifically Rocephin is first line. If the other cephalosporins, the oral ones, are all second line. So Rocephin, 250 milligrams IM, not IV, but IM. Okay, anything else? Okay, so everybody's saying Rocephin. There we go. Lisa says azithromycin. Okay, Rocephin and azithromycin. So you want to treat with both of those. Okay. So ceftriaxone, which is Rocephin, 250 milligrams IM times 1, and azithromycin, 1,000 milligrams times 1 PO. And Al is saying what to do if they're allergic. So those, you can look at those. Excuse me. It used to be that we co-treat it. If you test it positive for gonorrhea, then we co-treat it with the azithromycin to cover chlamydia because it does treat chlamydia. But now they're starting to begin to see a little bit of emergence of resistance of gonorrhea to the cephalosporins. So azithromycin is added not only to treat in case they have chlamydia, which she does not have, but it is synergistic with the ceftriaxone, and they're hoping to decrease the rate of resistance by using both of the medications. Ceftriaxone for testing, yeah, I think I have ceftriaxone on I usually use generic names, so ceftriaxone for testing purposes. Okay, partner management. Robert's sex partners within the last 3 months. So Laura is his current everyday sex partner. I don't know what to call it. The last exposure was vaginal sex 2 days ago, and he's been with her 2 months, I think it said. Monica was the one-time exposure, and that was 3 weeks ago. And then Geraldine, the last exposure was 3 months ago, unprotected vaginal sex. So who needs to be tested? Laura and Monica. Okay. So what's the guideline? Test all people within how long? 60 days. Okay. So you're going to test all partners that he's had in the last 60 days. So Monica and Laura fall into that. Okay. So Laura was examined and her lab results come back negative for gonorrhea and chlamydia. How should she be managed? He had sex with her 2 days ago. And everyone's getting that right. You want to still treat her with Rocephin and azithromycin. And what tests should Geraldine and Monica have? Well, Geraldine, I think we decided, okay, the NATS test. I think Geraldine, we decided didn't need testing. So on to this. So Geraldine, last exposure was greater than 60 days, so we're not going to worry about testing her. So Laura, we are going to evaluate and treat her presumptively, which means not wait for the test results to come back. If she's only had contact 2 days ago, she could have been infected and does not have a positive test yet. So you want to treat her presumptively. So she's going to get ceftriaxone and azithromycin, same dose as if she had the infection, so 250 of ceftriaxone and a gram of azithromycin. And then recent sex partners within 60 days should be referred and evaluated for testing and given dual treatment also. And so Monica, you would also test for GC and chlamydia and treat her presumptively. Okay. So follow-up. Robert returns 4 months later for employee-sponsored flu shot. He took his medication as directed, is asymptomatic, and has had no sexual partners since his office visit to you. Maybe he's learned his lesson. Does Robert need repeat testing for gonorrhea? No. Okay. No, he does not. You don't do a test of cure on gonorrhea. And what is the appropriate prevention counseling for Robert? Protection. Okay. Use of condoms. Obviously, limit your sexual partners, condom use, things like that. Decrease trips to Vegas. Okay. And someone asked how long it usually takes the NATS test to become positive. I don't think it's very long, but 2 days would be kind of cutting it close. So you could get a false negative. And if a partner has, a partner is positive and you know that they had unprotected sex, then you're going to treat them presumptively. You don't even need to wait. Okay? But usually it will turn positive probably within several days. Okay. Okay. Any questions on that? Okay. And then follow up. Robert should be retested. Are both of these single doses? Yes. All the treatment for gonorrhea for non-complicated, oral, vaginal or urethral gonorrhea is single dose. So ceftriaxone and azithromycin, single dose. Robert should be retested in 3 months or at his next provider visit. And again, this is not a test of cure. Those regimes are very effective. There's been, very little resistance to that, but you're rescreening for reinfection because he's been shown, to have high-risk behaviors, so you want to rescreen him to see that he's not infected again. And then obviously educate about safe sex practices, condom use, signs and symptoms of STDs. Do you rescreen everyone? For GC and chlamydia, yes, you do at 3 months and you're rescreening again for new infection, not for treatment failure. And that is just because, if they've had one, then obviously, there's something in their behavior that's making them more at risk. And a lot of these, especially like chlamydia, has very little symptoms. And even gonorrhea in females, in males, gonorrhea usually has urethritis. So they're usually going to know that they have it. But females don't usually have symptoms. So you need to rescreen to make sure that they don't have it. Sometimes their partners don't go get treated. Sometimes their partners say they went and got treated, and then they don't. So you just need to rescreen and make sure that they haven't gotten reinfected from a partner. So rescreen in 3 months. Okay. And I've had patients come back, 2 weeks later with symptoms, and they'll say, well, I had treatment 2 weeks ago, and I said, well, did your partner get treated? I don't know. Have you had unprotected sex with your partner? Yes. But I got treated 2 weeks ago. I'm like, the antibiotics don't go forward. They treat what you had 2 weeks ago. They don't treat, if you continue to have unprotected sex. And the other education that they need to know is to not have any unprotected sex with that partner until they are sure that that partner has been treated. That's, you would think that would be a no-brainer, but it is not. And we usually advise them not to have intercourse for at least 7 days after they've been treated. 7 days or until both partners are treated and no longer have any symptoms, but at least 7 days. Anatolia asks, so on question 7, we said no repeat testing for cure, but we rescreen at 3 months. So then we really should say yes. Well, you're not doing, I'm sorry if that's confusing. And someone asked I think it was Brittany asked in the forum, and I went over that. You want to rescreen for new infection. You're not testing for cure. So there's a difference. In some patients, you are going to test for a cure. What circumstance would you test for a cure with somebody with an STD? If they were what? What condition? Okay, if they're pregnant. Okay, if they're pregnant, you're going to test for cure. But for people that are not pregnant, you don't test for cure because both chlamydia and gonorrhea, if you know that they took medication, you give it to them in the office or whatever, is very highly effective. So you're not testing for cure, but you are rescreening. Okay. So I'm sorry if that was confusing, but you want to rescreen at 3 months or their next visit. The only time you're going to test for cure is if they're pregnant. Okay, any other questions about gonorrhea? Move on. Yes, Brittany asked if the term test for cure will be on the test. If I ask about retesting, I will ask about rescreening or test for cure. So I would differentiate between those two because they're for two different purposes. One is to see if the original infection was treated effectively and is gone. The other one is to see if they have a new infection from another encounter. So those are two different things. So one would be called a test of cure, one would be called just rescreening. Okay. So case 2 is Roberta Patterson. And Roberta is a 26-year-old woman that presents for her first prenatal visit. She's concerned for her baby because her husband has a history of genital herpes. She states she is 6 weeks pregnant, has never had any symptoms of oral or vaginal herpes. She was diagnosed and treated for chlamydia 7 years ago at age 19. No other STD diagnosis was reported. Her 26-year-old husband had his first episode of genital herpes 8 years ago. No other STD diagnosis reported. No visible herpes simplex lesions since the time that they've been sexually active, and reports having no prodromal symptoms or symptoms of active disease in that time. And they haven't had any other sex partners in the last 16 months other than each other. Her vital signs are normal, and it does look like she has a little bit of fever, though. 38 point, that might have been a typo. I might have done that by accident. Let's say she doesn't have a fever, okay? Cooperative, good historian, chest, heart, and musculoskeletal abdominal exams are normal. Her uterus is consistent with a 6-week pregnancy. She has a normal vaginal exam without signs of lesions or discharge, and no lymphadenopathy. So given that Roberta's husband, Franklin, has history of genital herpes, would it be appropriate to test Roberta for genital herpes using the type-specific serologic test? So should you do a serologic test? Yes, okay? You want to know what type of herpes, type 1 or type 2 they have, and what other STD screenings should be considered for her. This is her first prenatal visit, so think back to 568 when you had your prenatal testing. What other STDs do you screen them for the first time? Everybody, regardless, when they come. HIV, RPR, chlamydia. Okay, so you're going to test them for gonorrhea, chlamydia, HIV, and syphilis. You don't always check for herpes, but she has a history of exposure to herpes, so you do check on her. But everybody gets those others. Okay, so Roberta should have type-specific HSV screening, and the other routine STD screening for first prenatal visit is GC and chlamydia, HIV, and syphilis testing with either RPR or VDRL. So her laboratory results, the HSV type-specific serology, HSV1 was negative, HSV2 is positive. What are the differences between those two? HSV1 and HSV2. Kind of a trick question. Natalie says oral and genital. And that used to be so. They are transmitted, they both are transmitted by fluids, so either one. And Mariah says they can cross. So now, if you get a positive HSV2, it usually means anogenital herpes, that you've been exposed to that. HSV1 used to be the herpes that you get cold sores. So a lot of people will test positive for HSV1, but you can't really tell anymore because if you're having oral sex, then obviously you can get HSV2 in the oral area, and so it's a little bit misleading. The DNA probe for chlamydia was negative. The culture for gonorrhea was negative. RPR was non-reactive. HIV test was negative, and her pregnancy test was positive. So what would you tell Roberta about her HSV infection based on the clinical manifestations and test results? Does she have active herpes? So she's been exposed to herpes. She tests positive for antibodies, but she's not having any active lesions. And would routine viral cultures during her pregnancy be recommended? Would you just culture her every few weeks or anything if she's not having any symptoms? Okay, no, because you already know she's been exposed to HSV2. So you know she's positive for that. And cultures really are not very accurate unless you have an active lesion. And once they start to heal, viral cultures are really difficult to get. Okay, so management. She should be informed that she tests positive for HSV2, indicating that she's had infection at some point. The test cannot determine when the infection occurred, and based on her clinical evaluation, she doesn't have an active infection at this time. Routine cultures would not be recommended. It's already known that she's positive. If she has an outbreak, then you could do an HSV viral culture, and she could be treated with an antiviral medication, such as famciclovir or acyclovir, one of those. Okay, so partner management. Franklin is her partner, and first sexual exposure 16 months ago, last sexual exposure 1 month ago. He has a history of genital herpes infection, first episode 8 years ago, and no HSV testing or treatment at the time of the first episode or with subsequent episodes. So he might have just, a lot of times you do it based on just empiric, looking at the, clinical evaluation. You see active lesions and you treat them. He has no history of other STDs and no sex partners other than Roberta in the past 16 months. He reports genital lesions during the 6th month of her pregnancy. What lab tests should you perform on him when he reports these lesions? Then Al says a culture, so now is when you're going to do a culture, okay? So you would do HSV cultures, and that is, just like a wound culture. It's a swab, and you really have to kind of denude the ulcer if it's already healing to get the secretions. It's not very sensitive unless you have an active lesion that's kind of like especially if you have the blisters or anything, you can break a blister, you're more likely to get a positive culture. So what is an appropriate episodic treatment for Franklin? Acyclovir, famciclovir, any of the cyclovirs, and usually, how long do you usually give it after they've, now he's had episodes before, so his is a recurrent episode. How long do you usually give it? Okay. The first episode you give 7 to 10 days, usually 10 days, and the next episode you usually give about 5 days. Okay. Okay, so here's all the 3 big ones are acyclovir, valcyclovir, and famciclovir. But as long as you recognize that, they're all cyclovirs. They're all, as I've told you before, with all medications, always look at the end of the word, because a lot of them, when you get to blood pressure in the next section, you're going to have tons of blood pressure. But if you look at them, all the ARBs have TAN at the end. Almost all the beta blockers have LOL at the end. Metoprolol, all those. So look at the end of the word and remember them by class. Okay. So these are all the cyclovirs, and for a recurrent regime, it's usually for 5 days. There are some that are 3 times a day, some that are once a day. Obviously, you give them. You want to try to go with something, with all medications for all disorders. The less number of doses, the better for compliance. But this is going to be the most expensive one. And this is going to be $4 at Walmart. So, and for the original, for the first one, one of the regimes used to be 200 milligrams 5 times a day. Try to get somebody to take some medicine 5 times a day. But that was the only thing that was on the $4 list at Walmart. So, it just varies. So you can, you don't, these are something you would look up. I do want you to know what class of medicine, recognize them, but you don't need to remember the actual doses. And, you should know how long. It's usually 10 days for the first, 5 days for recurrent. Yeah, like a Medrol dose pack. Yeah, take a lot of those. Okay, follow-up. Roberta has had no HSV symptoms during her pregnancy. She's discussed the use of acyclovir treatment in late pregnancy with her midwife, but decided against it because there was no data to support use of antiviral therapy for HSV seropositive women without any clinical herpes lesions. At the onset of labor, she reports no prodromal or other HSV symptoms, and no lesions are seen on exam. After 14 hours of labor, she vaginally delivered a healthy 7-pound girl. What questions should you ask all women when they go into labor if they're positive, or if they know that they have well, you should ask all of them if they know that they've been exposed to HSV. So ask them about symptoms. Ask them about prodromal signs, which are signs that they get before. What kind of signs do they get before an attack? Anybody that's had a fever blister probably gets the same thing. Tingling, burning, itching, things like that, usually a day or two before the actual lesions appear. So you want to ask her if she's had anything like that, or if she's actually had any actual blisters. Okay. I don't know if any of you have seen herpes. It usually starts as a blister, then pretty rapidly ruptures, and then you have a very tender red ulcer, and then it clears up. But you may have seen people in the ER that are just, have 10, 15, 20, just the labia is covered with these. Very, very painful. They need not only the cyclopiers, but they need pain medication, and they really have difficulty urinating because it just burns so much. So what you can tell them to do is put 2 or 3 inches of warm water in the bathtub and urinate in the bathtub into the water, because the water dilutes the urine, it's not hitting the perineum, and then just Clorox the bathtub afterward. But they sometimes have to do that for a couple of days because it's so painful for them to urinate. If Roberta has genital herpetic lesions at the onset of labor, should she deliver vaginally or abdominally, and what is the risk to the infant? Abdominally, she should have a C-section, and the risk is transmission, of herpes to the infant, which can be very serious because they can get neurologic symptoms and everything. They can get meningitis. Okay, so anyone that had positive symptoms or lesions is going to have a C-section. Okay, management of labor and delivery, questions that should be asked. Do you have a history of herpes infection? Do you have any lesions? Do you have any prodromal symptoms? If she had lesions at the onset of labor, she should have a C-section, and the risk to the infant of vaginal delivery is transmission of herpes to the infant. Roberta is asymptomatic at delivery. Is it medically appropriate to deliver vaginally? And this is kind of rhetoric since we've already said she delivered vaginally, so yes. And if she had acquired herpes around the time of delivery, if she had acquired herpes at or around the time of delivery, would she be more or less likely to transmit it to the baby during a vaginal delivery than if she had recurrent herpes? So she had herpes 6 years ago. Which one would be more? She'd be more likely. The more recent the onset of the active herpes lesions, the more risk for viral shedding. So the more risk for the baby. Oops. I have 2 of those. I guess. Yeah, I have to delete one of those slides. Okay, any questions about herpes? Reason we treat longer at first also. Yes, Mariah asked, is that the reason that we treat longer, the first episode longer? You treat that one longer because most first episodes of herpes are more severe. They're more likely to have fever and body aches and just more severe symptoms. They're greater viral shedding, and so you want to treat them for a little bit longer. And the 5-day treatment for recurrent, if they have, maybe they're a little immunosuppressed or something, you can extend that 5-day treatment if their symptoms aren't gone by 5 days. So it's not, the 5-day for recurrent is not hard and fast. If they're still having symptoms, then you can extend that treatment on. Melissa said she's read that some doctors give acyclovir at 36 weeks to be safe for vaginal delivery. Is that with somebody that they know is positive, or just for everybody? Okay, and that's somebody they know is positive. And there are, some, giving prophylactic acyclovir does help decrease shedding of the virus. So if they have, an occult, I guess, maybe lesions that you can't see or something. So that's why, I did put in these are from the CDC. I put the answers, but the actual questions are from the CDC. She did discuss the use of treatment of acyclovir in late pregnancy, but the data doesn't really support that it's going to do anything different if they're not having active lesions. Probably not going to hurt them, but it's not necessarily going to. A careful exam to make sure that she's doesn't have any lesions at the time of delivery is going to be the safest thing. Okay. So case 3, is Stan Carter. And Stan is a 19-year-old who presents to the STD clinic with a complaint of a penile lesion for 1 week. His last sexual exposure was 3 weeks prior without a condom. He has no recent history of travel. He predominantly has female partners, 3 in the last 6 months, an occasional male partner, 2 in the past year. His last HIV antibody test 2 months ago was negative. Physical exam, no oral, perianal, or extragenital lesions. Genital exam disclosed a lesion on the ventral side near or at the frenulum. The lesion is red, indurated, clean-based, and non-tender. There were 2 enlarged tender right inguinal nodes. The scrotal contents were without masses or tenderness. There was no urethral discharge, and he had no rashes on the torso, palms, or soles, no alopecia, and his neuro exam is normal. So when you're thinking, certain diseases, you want to look at all these. Those are the symptoms. What are the possible etiologic agents that should be considered in this differential? So he has no penile discharge, but a lesion. Syphilis, anything else that causes an ulcer? HSV could be. What's the difference, syphilis and HSV, in the ulcer? Pain. Okay, Brittany says pain. HSV has a painful ulcer. Syphilis has a non-painful ulcer. Okay. Anataya says chlamydia. He doesn't have any, and chlamydia, it can be because it's asymptomatic in most. So, you're going to want to test him for that. Anything else? There's one other thing that causes, the name is very close to the name of what we're describing. What is this ulcer called? Okay, it's called a chancre. So what's the other disease? Chancroid. Michelle said it, chancroid. That's the other disease that causes an ulcer, okay? And that's a different bacteria. Okay, so what is the most likely diagnosis? Okay, syphilis. And what laboratory tests are we going to do on him? An RPR, or what's the other test? VDRL, okay. Are you going to test him for anything else? HIV. He's at an STD clinic. What else are you going to test him for? You could do dark field microscopy if that's available in your area. You could do the NATS test for what? Lisa and Melissa, what are you looking for on the NATS? Okay, GC and chlamydia. Okay, so anytime you have someone for STD screening, you're going to do GC, chlamydia, HIV, syphilis. You want to test for all of it. If they're having behaviors that make them at risk for one, and their same behaviors that make them at risk for all those. Okay. So differential would be syphilis, chancroid, or HSV. Most likely syphilis because it's non-painful. You could do dark field exam of the exudate from the ulcer if it's available in your area. It's not available very much anymore just because the serologic tests are so much easier to do. The troponal serologic tests are the ELISA tests. The non-troponal are VDRL or RPR. Those are both serum tests. If one type of test is positive, it's not sufficient for diagnosis because you can have false positives, so you need to use the other type to confirm it. And he should be tested for other STDs such as GC, chlamydia, herpes, and HIV. Okay. And you don't test everybody for herpes, but if they have an ulcer, yes, you do. So, but somebody that comes in with urethral discharge or dysuria, unless they have ulcers, you don't, or have a history of contact with somebody with herpes, you don't necessarily test them for that. So the lab results, the stat lab shows RPR is non-reactive, and I guess on this CDC thing, the dark field, they did have a dark field exam, and it was positive for T. pallidum, which is the, so what is the diagnosis? Okay, this is syphilis, okay. And what is the appropriate treatment? How do you treat syphilis? Penicillin. Okay. So primary diagnosis is primary syphilis. The appropriate treatment is penicillin G, 2.4 million units IM times 1. If there's penicillin allergy, doxycycline or tetracycline for 14 days. When is this change, this allergy treatment? Under what circumstances? Pregnancy. What do you do if they're pregnant? I might have it on another slide. I can't remember. Admit for what? Desensitization. Yeah. The only treatment for syphilis in pregnancy is going to be penicillin. So you admit them and have them desensitized to penicillin. And that would be you wouldn't be doing that. That would be an infectious disease person that would be doing that. Okay, so reference labs, that got sent out, came back. The RPR was non-reactive. The non-troponal test, the FTA, was reactive. HSV cultures were negative. Gonorrhea and chlamydia were negative. HIV was negative. And did the reference lab results change your diagnosis with this RPR being non-reactive? Obviously. I have the result. I have the thing. I didn't even realize I put the answer. The answer is right there. The reference lab results do not change the diagnosis because in early infection, RPR can be negative, falsely negative, because it's in the early stage. So that's why you need to look at both of them. Okay, so Stan's sex partners, Tracy, last intercourse 3 weeks ago. Danielle, last intercourse 6 weeks ago. Jonathan, 1 month ago. Tony, 8 months ago. Carrie, 6 months ago. Which of his partners should be evaluated and treated prophylactically even if their test results are negative? Okay, Tracy. Anybody else besides Tracy 3 weeks ago? Danielle? Okay, all except Tony and Carrie. So basically, anyone in the last 60 days. So, and it's a little longer, it's 90 days for syphilis, because syphilis can take a long time for your test to become positive. So, so these two are 6 and 8 months ago, so you're not going to have to treat them. So all partners should be evaluated and tested. So you want to let him, and this is a state reporting disease. So whether he tells them or not, the state's going to tell them. So everybody should be evaluated and tested, but they're not all going to be treated, okay? All partners within 90 days should be treated prophylactically, even if the tests come back negative. So that's Tracy, Danielle, and Jonathan. But everybody is going to be evaluated, okay? And partners greater than 90 days should be treated prophylactically if the test results aren't available, if they can't get serologic tests, or if follow-up is uncertain. So sometimes you get a patient and they're just not reliable. So you want to err on the side of caution. If they come in and you know that they're not going to come back, we had that a lot at the health department where the state would track them down and get their test, but if they felt that the person probably wasn't going to come back for follow-up and to get the actual results of the test, because those don't come back. This isn't like a 1-hour test. Then you can just prophylactically treat them because you don't want them spreading it to other people. Because remember, with syphilis, that primary ulcer can be very small. It heals up within a week or two without treatment and goes away, and then they really don't have any other symptoms until they get to secondary syphilis. So they can have it for a long time and be spreading it without knowing it because they just kind of missed that ulcer. I had a student with me one time about 5 years ago at the health department, and we were getting ready to go in to see a male STD, and of course the student, it was a female student, she was all nervous about doing that, and I said, we go in, we talk to him about his sexual history, and we had a very straightforward form, and you could just read off of it, how many female partners, how many male partners, anal sex, oral sex, vaginal sex, all that. We just kind of checked it off, and asked about their symptoms, and I said, and then have them open their mouth, look at their oral pharynx, look at their skin, and then just ask them to lower their trousers and do the genital exam, and so we go in, and it was a young man in his early 20s that had been, he came in to be checked. And that was always the red flag when they just said, I just want to be checked. He had been in jail for the last 8 or 9 months. So, when you asked him, and he was laying on the counter, like this, and it was like, can you sit up and talk to me, please? Am I interrupting your nap? They came to me. But he was not the most responsive, giving grunting answers or, yes or no, or very little information. Have you had any sexual partners in the last 6 months? No. Any female partners? No. Any male partners? No. Any oral sex? No. And so, she, we're going along, and then she asked if he had any, genital lesions, and he said no. And she said, have you had any oral lesions? And he said, oh, you mean like this? And he lifted up his lip, and he had a great big chancre right up on the top of his gum. And I had never seen that before. And we were just both like, oh, my goodness. And everybody else in the clinic had to sneak in and take a look because I had not seen that. But, you just say, okay, and we went ahead and treated him that day because we didn't know whether he would come back, just presumptive that he had syphilis. That is not uncommon in incarcerated patients, to have sex and not disclose. So what tests did you say must both be positive for diagnosis? If Jennifer asked which tests should be positive, if you do a troponeal and a non-troponeal, if one of them is positive, you want to do the other one to confirm. Now, that doesn't mean that you can't go ahead and treat them, but you want to do the other one to confirm because there's a whole list of conditions in the CDC PowerPoint that cause false positive tests for syphilis. So you want to confirm it with both of those tests because, not just treating them right then is important, but following up on their partners and stopping it is the main thing. So you want to know for sure whether that is positive. Okay. So the partners 30 days, 90 days, greater than 90 days should be treated prophylactically if you don't think that they're going to come back. If they do come back for follow-up and their tests are negative, they don't need treatment. So that would be Tony and Karen. Does that make sense? So test everybody for syphilis, but treat them less than 90 days. Okay. So Stan's partner, Tracy, is found to be infected and diagnosed with primary syphilis. She is also in her second trimester of pregnancy and allergic to penicillin. So I guess I did have this already. So we've already talked about the appropriate treatment for Tracy, and that would be admission for desensitization to penicillin. Okay? She should be admitted to the hospital and desensitized to penicillin by an infectious disease provider. Because that's the only known effective treatment to prevent transmission to the infant. And as you can see from the CDC PowerPoint, congenital syphilis causes all kinds of problems. So you want to be very aggressive about that. Okay, follow-up. Stan returned to the clinic for follow-up exam 1 week later with the following results. His penile lesion is almost completely healed. He has not experienced I don't even know how you say this, Jarisch Hexheimer reaction. The RPR repeated at the follow-up visit because the initial one was negative is now positive. And what type of follow-up evaluation will Stan need? When will you test him again? He had primary syphilis. Okay, 6 and 12 months. Al said 6 and 12 months, which is correct. So you're going to repeat those RPRs at 6 and 12 months. And then what are the appropriate preventative counseling messages for people with syphilis? This is going to be the same for all the STDs. And so, condoms, limit partners, all those kind of things. Not have sex with another partner if they haven't gotten treated yet. So you're going to re-examine at 6 and 12 months, and the follow-up titers should be compared to the maximum or baseline non-tuberculous titer that you got at the day of treatment, and you should see that going down. Prevention counseling, risk factors, transmission, safe sex practices, and condom use. And then I just put a little bit here about what that reaction is, the Jarisch Herxheimer reaction, and that's an acute self-limiting febrile reaction that occurs within 24 hours after the patient receives penicillin for syphilis. It occurs in 10 to 35% of patients. It's most commonly seen in early syphilis. The fever can be accompanied by all kinds of other constitutional symptoms like myalgias and headaches and chills and diaphoresis, and worsening of the rash. And there really is no treatment for it other than Tylenol and Motrin and things for the fever and the body aches, and it does go away. Is the RPR the only test you repeat at 12 and 6 months? I'm going to have to look that up. I can't remember which one, whether it's the VDRL or the RPR that you use for follow-up treatment, but that is in the CDC PowerPoint, and I'm not going to ask you that on the test. So as long as you know that you do repeat the test at 6 and 12 months, I won't ask you specifically which one. One of them you don't use for to see the titers going down, and I can't off the top of my head remember which one that is, but it is listed in the PowerPoint. Okay. Any more questions on syphilis? If they have this reaction, if Pamela asked if they have the febrile reaction, this Jarisch Hexheimer reaction, do they need to be hospitalized? Most of the time not. It's kind of feel like they have the flu. They have body aches and headache and fever, and it's self-limiting unless they're, HIV positive and severely immune depressed or something like that. But for most people, it's going to be a self-limiting reaction. And it is not a reaction to the penicillin. It just happens when you start to treat syphilis. So it is not a penicillin allergy. So they tell them not to tell everybody that they're allergic to penicillin after that. So, they can probably just take over-the-counter antipyretics. Okay, so case 4 is Susie Jones. Sorry, this is taking so long. It's a long presentation. Susie is a 17-year-old college student who presents to the health service seeking advice about contraception. She's shy about talking about her sexual practices, has never had a pelvic exam, has 2 sexual partners in the past 6 months, does not use condoms or any other contraception. Her periods have been regular, but she's noted some spotting between periods, and her last menstrual period is 4 weeks ago. And she denies any vaginal discharge, dyspareunia, genital lesions, or sores. Physical exam, normal vital signs, breast, thyroid, and abdominal exam are normal. Genital exam reveals normal vulva and vagina. The cervix appears inflamed, bleeds easily with purulent discharge coming from the cervical os. The bimanual exam is normal without cervical motion tenderness, uterine or adnexal tenderness. So what is the initial clinical diagnosis? Just clinical diagnosis. You don't have any lab tests yet. The purulent material coming from the cervix, red cervix, cervicitis. Okay? Natalie says cervicitis. That's correct. So she's got an inflamed, red, easily bleeding cervix with purulent discharge. So she's got cervicitis. What is the most likely biologic cause? It can be more than one. Chlamydia. Could be chlamydia, it could be gonorrhea, it could be any of those. Okay? What laboratory tests should be performed? Okay. The NAT test for both GC and chlamydia. And again, she's sexually active, not using any protection, more than one partner. You're going to test her for everything. RPR, VDRL, HIV, test for everything. Okay? The same behavior that causes one disease causes them all. Okay, so initial diagnosis. Okay, and we didn't go over this. So what, say you don't get, well, let's not just do that. Okay, so we said that the most likely diagnosis is going to be chlamydia. What would be the appropriate treatment for that, since it's on the next slide? For chlamydia. 2 choices. Azithromycin, or what's the alternative? Doxycycline. Okay, azithromycin or doxy. Okay, so the initial diagnosis is cervicitis until you get back her labs. The most likely biologic diagnosis is going to be chlamydia. Her lab tests, you'd want to do the NAT for GC and chlamydia, RPR or VDRL, HIV. Also a wet prep and a urine pregnancy. She's she's having unprotected sex. Her last period was 4 weeks ago. Need to find out if she's pregnant. A wet prep would check for what? What are you checking for with a wet prep? BV. What else? Trichomonas, correct, and yeast. Okay, so you need to do a wet prep. There are rapid antigen tests now for BV and Trick. I don't know how often they're being used. We're still sending wet preps in the ER, and so they're not using the new ones yet. Appropriate treatment is azithromycin 1 gram PO times 1 or doxycycline BID for 7 days. Okay. And when I was at the health department, we gave out the medicine. We dispensed it there because most of them were there, didn't pay anything. And we were supposed to save this for pregnant women, but giving doxycycline twice a day for 7 days, what's your, chance that a 17-year-old is going to take all 14 pills? Not real great. So we gave as much as we could. We gave the 1 dose azithromycin. So it's always better to do fewer doses. Lab results came back. Chlamydia came back positive. Gonorrhea came back negative. RPR negative. Wet prep was pH of 4.2. No clue cells or trichomonas, but numerous WBCs. KOH was negative for whiff test. HIV antibody test was negative and pregnancy test was negative. Did you get to do wet preps at intensives? We used to do those, and then they didn't. Okay, great. So what did they have you look at? They have simulated slides or something? Look at slides. Okay. Was it, I mean, I don't imagine that it was modal simulated slides. That's what I was thinking. Okay. Hopefully some of you, when you're in GYM, will, work at a practice where you do get to do some wet preps. And the first time you see trick, you won't forget it after that, after the first time you see it. And it's, it's hard to see. They're very tiny. They're almost shaped like sperm. And you can mistake trick for sperm, but their tail actually is 2 little flagella instead of just one like a sperm. And it almost looks, you sit there and you're looking, and it almost looks like it's vibrating. You just see this little thing that's just going like that, and that's trick. A lot of times, unless, let's get the wet prep done really, really quick and have enough saline on there, they're not actually swimming, they're just kind of moving. And once you see it, then you start looking around the slide, and there's one. Oh, there's one. So, and pregnancy negative. Okay. So final diagnosis, what's the final diagnosis for her? What are appropriate prevention and counseling for her? Okay, her final diagnosis is chlamydia. So we're going to give her the routine STD prevention talk, but what else are we going to talk to her about? Birth control, correct. Okay. She's here and she's shy about talking about being sexually active. I used to see so many girls and I say, are you sexually active? Yes. Are you using contraception? Well, first of all, you can't say contraception because they don't understand that. So birth control, no. Do you want to get pregnant? No. Okay. Well, we've got a mismatch here. You don't want to get pregnant. You're having unprotected sex. It's not if, it's when. You will get pregnant. So make sure that, use any encounters, whether they're there for STD or anything, to reinforce contraceptive practices so that they don't have an unintended pregnancy. Final diagnosis was chlamydia. Signs and symptoms of chlamydia, usually asymptomatic, so that's why we want to screen for it. You want to tell them how it's transmitted, safe sex practices, condom use, and risks of being untreated. What's the big risk of chlamydia if it's untreated? PID, and what's the long-term risk? And they're going to get, what happens if they get PID? Infertility, okay? So scarring of the tubes and infertility. And if they have chlamydia or gonorrhea, we talked about abstaining from sex until 7 days after both partners are treated. Very important. And that's, so if the other partner doesn't get treated for 5 days, then they wait 7 days after that partner is treated, okay? So both partners need to have been on, have had their treatment for 7 days before they have intercourse again, and hopefully with protection. Susie's sex partners for the past year: John last exposed 5 weeks ago, Tom last exposed 7 months ago, and Michael last exposed 2 weeks ago. Which ones need to be evaluated, tested, and treated? How many months? Okay, John and Michael. Okay, so we're going to do 60 days. Gonorrhea and chlamydia, you go out 60 days, so John and Michael. Her follow-up visit at 4 months, her repeat chlamydia test returned positive. She states that her partner Michael went to get tested, but the test result was negative, so he was not treated. What's the appropriate treatment at the 4-month follow-up visit? Okay, retreat. Okay, so maybe he did go and get tested, maybe he didn't. Maybe it was negative, and if he went right away and he was negative, then I would have treated him presumptively just because it might not be positive yet, just like we do with gonorrhea. But either way, if she's positive again, again, this is not a test for cure. This is a test for reinfection. The antibiotic that you gave her, the azithromycin, was probably effective in treating her, but then she had intercourse with somebody who still had the infection, and so she has a new infection. So the appropriate thing to do is to retreat her. McCurry says, in the ER I work, they prescribe azithromycin 1 gram, ceftriaxone 125, and metronidazole all the time before getting the results. If they suspect an STD, is this how you usually practice? Yes, it is. In the ER I work in now, we get the GC and chlamydia back usually within an hour or so. Wet prep, sometime we get back quickly and sometime we don't. It just depends on the time of day. If it's 11 o'clock at night, we're not going to get it back. So I do treat prophylactically a lot of times, because a lot of times you don't know how honest they are, how many partners they've had. A lot of times they don't know which partner it is. If they've had multiple partners, then they don't really know when they got exposed. So you don't know if they got exposed yesterday and their tests just aren't positive yet, or if they got exposed 2 months ago. So if they're having symptoms of cervicitis, dyspareunia and red cervix and purulent discharge, I treat them for everything. I treat them for gonorrhea, chlamydia, and trichomonas. So that, we do that a lot. Okay, so follow-up, treat with azithromycin or doxycycline again, just like you would the first time. It's most likely a new infection, not a treatment failure. Okay, any questions about chlamydia? We'll move on to the last case. Okay, Jane Wheels is case number 5. And she is a 24-year-old who presents with lower abdominal pain, cramping, slight fever, and dysuria for 4 days. That's fine, Venus. Have a good day. She's Para 1, Grava 1. Her last period was 2 weeks ago. She's regular without dysmenorrhea, and she uses oral contraceptives for the past 2 years. She reports gradual onset of symptoms of lower bilateral abdominal discomfort, dysuria, but no gross hematuria, abdominal cramping, and a slight low-grade fever in the evenings for the past 4 days. The discomfort is gradually worsening. She denies any GI disturbance or constipation and denies any vaginal discharge. She states she's happily married in a monogamous relationship and plans another pregnancy in about 6 months. There's no condom use, no history of STDs, and reports an occasional yeast infection. She douches regularly after menses and intercourse, and last douche this morning. Physical exam has a little bit of a fever, but other than that, everything's normal. Her neck, chest, breast, heart, and musculoskeletal exam are normal. No flank pain on percussion, no CVA tenderness. It's basically the same thing. On an abdominal exam, the patient reports tenderness in the lower quadrants with light palpation, and several small inguinal nodes are palpated bilaterally. She has a normal external genitalia exam with no lesions or discharge. Speculum exam reveals minimal vaginal discharge with a small amount visible at purulent mucus at the cervical os. And bimanual exam reveals uterine and adnexal tenderness, as well as pain on cervical motion. The uterus is anterior, midline, smooth, and not enlarged. So what should be included in the differential diagnosis for her, and what lab is going to order? That's cervicitis, correct. PID, correct. Okay. WBC, UA. So we're going to do a UA and look for urinary tract infection. What else? What other tests? Gonorrhea, chlamydia. Okay, wet rep. Susan up here said gonorrhea, chlamydia as possible problems. Pregnancy test, yes. Okay. So, differential diagnosis, B, or she could have an ectopic pregnancy. She's got, unprotected sex, and she's got adnexal tenderness. You always have to rule out ectopic pregnancy when anybody has capability of getting pregnant and adnexal tenderness and cervical motion tenderness. You want to do a urine HCG to check for pregnancy, GC and chlamydia. Remember, you're going to check for all the STDs if you're thinking cervicitis or PID. So check chlamydia and gonorrhea, HIV, RPR or VDRL to check for syphilis, wet prep for yeast, trick and bacterial vaginosis, a CBC, a CRP, and a SED rate. Okay. Laboratory office results. The urine pregnancy is negative. Urine dipstick is negative for nitrates. Kind of gives you an indication that she probably doesn't have a UTI. Vaginal saline wet mount, the pH was normal. Microscopy shows a lot of white blood cells, but no clue cells, no trichomonas, and the KOH is negative for budding yeast and hyphae. So what is your presumptive diagnosis? You don't have the rest of the lab results back. Okay, PID. So we've ruled out pregnancy and probably ruled out UTI or trick or BV. And so we're thinking PID. And what is going to be the, I don't know if I have it. Okay. So I'm just going to go over we're running late. I'm going to go over everything. So presumptive diagnosis is PID. This is most commonly caused by GC or chlamydia. It can be managed as an outpatient, but if there's no improvement in 72 hours, then they should be hospitalized and given one of the IV regimes. I want you to know the first-line oral regime. You don't need to know the IV regime. Appropriate treatment is to treat both the chlamydia and gonorrhea with ceftriaxone 250 plus doxycycline 100 BID for 14 days, not for 7, with or without metronidazole. So this would treat trick, plus it also just extends the coverage of the ceftriaxone. So this is the first-line treatment for PID. And every time I've done it, I've gone ahead and added some metronidazole, which is Flagyl. Okay. It's good for anaerobic infections. On follow-up 3 days later, she's clinically improved. And again, if she is not, if she's still febrile or having, any more symptoms, they need to be admitted. The culture for gonorrhea was positive. The test for chlamydia was negative. Joseph, her husband, came in at her follow-up. He was asymptomatic but did admit to a one-night stand while traveling, and so he was treated. They were offered HIV testing, which they accepted. Partner management. His first exposure to his spouse was 4 years ago. Last exposure 1 week ago. Frequency 2 times a week. So how should he be managed? What should he get? Al asks, would you recommend additional antifungal treatment due to her history of occasional yeast infection? You could, since she's getting a bunch of antibiotics, if she's prone to yeast infections, then you could give her a diflucan to, hopefully ward off a yeast infection. Brittany says he should be shot. Okay. So he should be tested for both gonorrhea and chlamydia. His gonorrhea came back positive, so he is given the usual treatment for gonorrhea, which is ceftriaxone, 250 IM times 1, and 1 gram of azithromycin PO times 1. Okay. So, any questions about anything we've gone over? I know that was a lot. I'm trying to get these under an hour, but just can't quite do it. So if you see, gonorrhea is ceftriaxone and azithromycin. Chlamydia is azithromycin or doxy. syphilis is always going to be, penicillin is always going to be number one. Herpes is going to have all the cyclovirs. So there's really, and then PID you're going to treat for both. And you might throw the metronidazole in there for good measure. Trick is metronidazole. BV is metronidazole, flagyl. So there's really not that many medications. So don't get bogged down thinking there's a ton of medications. Let's see. Kimberly asked, would we discourage douching at this point? I think that's part of education, is you should tell women that douching, is not really recommended. So, you might want to at least discuss that with her and tell her that, that that's probably not recommended. Will I be posting the PowerPoint that includes the answer? Yes, I will. I'm sorry, I should have said that at the beginning so that you're not writing everything down. I didn't want to post it ahead of time so that, you wouldn't have the answers right then, but I will post it as soon as I get off. And Kimberly, you can click on the download button to the lower left. Oh, I didn't know you could do that. Okay, so that's great. I didn't know you could download it yourself. So, and she says she doesn't see a download button. Okay, well, either way, I'm going to post it under the announcements in just a few minutes when I get off. So, any other questions about STDs? You've got your exam next Monday, and I posted an announcement. Remember that our exam time is 8 to 10 now, so make sure you don't wait until 11 to take the exam. Anything else? If not, I'll sign off. Okay, well, you're very welcome. Have a good evening. I'll see you later. Bye.